All right, we're back. Welcome to Last Month in Healthcare. We've not recorded since July. It's October.
So this is what, the last 4 months in healthcare or whatever, 5 months, something like that?
So that's actually part of, also, first of all, we're with Kyle Minick.
Yeah.
It's okay.
I mean, it's been 4 months. That's why they brought in a little bit of
we need to
extra
just come
energy.
back with a bang.
I'm Nathaniel. I'm Spencer's producer. If you, I guess, haven't watched the show before, it's a news show that we record at the end of the month, covering the last month. This one's a bit different because we haven't recorded in a while. Yeah. I have a different format for this one. But I'm Nathaniel. I'm Spencer's producer. Spencer.
Nathaniel's, this is his brainchild, but I host the Self-Funded with Spencer podcast. I really enjoy this format. I'm actually not even sure what to expect, which is kind of exciting. Nathaniel never preps me ahead of time. That's part of the whole gist here, is that I don't have any idea what's coming. And then we get a guinea pig like Kyle to join us, and he even has less foresight in what's coming.
If you don't know what's going on, then I certainly don't know what's going on.
Yep.
Just have fun. That's all you got to do.
I can do that.
Yeah.
So since, I was kind of thinking about, like, we haven't recorded in a while, should I go through and just find all the big stories and do all that? But my kind of thought was, like, I don't really want to talk about, like, 3 or 4 month old news.
Yeah.
And also, I just recently, when I was kind of going through the articles over the past week or two, I found a lot of articles about our doctors in America and kind of their experience as we go into, like, AI and, like, the whole payer model, like, they're not compensated as much and all the issues surrounding that. And so I wanted to make this a special episode. I'm going to make this the title of the episode is What's Going On with Our Doctors.
All right.
Okay. So I have 5 stories for the news section. I guess we'll just jump right into the first one. So physician stress returns to peak pandemic levels, survey says. 57% of physicians reported inappropriate feelings of anger, tearfulness, or anxiety, similar to 2020 to 2022. But during 2023 and 2024, those were at less than 50%.
Interesting.
So this is by the Physicians Foundation.
Did they speculate as to why?
They did. Okay. So it says their statement was, throughout 2025, the U.S. healthcare landscape has been reshaped by significant changes, ongoing consolidation in healthcare, evolving reimbursement models, the widespread rise of mis- and disinformation, and major leadership and policy shifts within government, affecting physicians' abilities to deliver cost-effective, high-quality care and transforming how physicians practice and engage with their patients.
Okay.
All of that fundamentally to me just is one big way of saying that patient load has gone up, reimbursement rates have gone down.
Yeah. So I feel like this is definitely in your wheelhouse. So expand upon that. So I have gotten a little bit of, like, information around the reimbursement rates going down, but, like, was there something fundamental that caused a shift where now they're being reimbursed less, or they're not being reimbursed at the same rate of inflation, or what's happening there?
Well, I mean, in my opinion, I don't know the most about this, but if I was just to look at news articles, headlines, and things that I've read over the last few years, I mean, you have a lot of insurance companies purchasing doctor groups, hospitals are purchasing specialist and physician practices left and right. So all of that aggregation changes what they fundamentally feel that they can charge. They don't have the power to control their own reimbursement rates, and they have to take on the increased patient load as a result, because there's less freestanding physicians and physician groups. So where do these individuals go? They go to the hospital systems.
Yeah.
Or the owned systems. HMOs are also becoming more and more prevalent, at least in the fully insured market. So what do you do with that? It's more managed care, so they have to take on more pathways or more patients. Then the rise of direct primary care, I think, is also indicative of that same frustration, because they want lower reimbursement rates, or they want lower patient counts for more stable income metrics that don't require them to see people or volume base their practice.
Well, we were just talking about Danish before, and I don't know if we captured that in the recording, but Danish Resilient, we were just talking about his model. And I do think the kind of proliferation of new versions, DPC 2.0 is happening right now as a response to that. Now, that's obviously solely primary care, but I think the burnout, I suspect a lot of this, like, self-reported burnout is coming from primary care physicians, and patient load being one of the primary motivators 100%. Of burnout. And so my hope is that the market, we were just having free market conversations on our episode. My hope is the market simply responds to these strains and says, hey, let's create a different version of that that's actually better.
Well, and my hope, and I'm going to make a bold prediction here.
Oh, all right.
I think within the next 5 to 10 years, we will see the majority of primary care physicians move to a direct model of some sort.
I don't think that's that bold. I think I agree with you 100%.
I just don't see how they can continue to sustain it. And I think hospital systems are going to feel the pain of that the most. And ideally what that will do is get them back to basics, which is specialty care, like emergency care and specialty care. Mm-hmm. And if that's what we start moving to, hopefully that puts a few things in perspective and has them change the nature of their business models, at least to the degree to understand that if they keep putting that much pressure on individual practitioners, they're going to lose specialists next.
Yep.
And specialists are going to enter into that same space. And my hope is also that it'll have a positive impact on insurance rates overall, because you're basically quantifying unknown usage into known cost and known risk.
Yep. Well, and I want to add one more thing. I know you're probably going to weigh in or move us on, but what I like too about DPC, especially when it's done well, is if that DPC fundamentally understands how to coordinate and care navigate outside of their walls. They understand the plan sponsor's actual plan design and what out levers they can pull, so they're getting people the right direction. Now you have a more efficient plan, not just in primary care, but in specialty care.
And I think that's a huge opportunity for the application of AI.
Okay.
A huge application for the AI, because if I'm a doctor, and I have even a DPC, I still have 500-ish patients, give or take, or maybe 500 to 700. That's a lot of health plans to keep track of.
Oh, yeah.
Right. So in that dynamic, you could use a tool like Healthy or something like that has an AI that knows how to read these plans and partner that with those physician groups so that they can direct care using the AI, rather than having to integrate themselves into that specific plan design or coordinate via TPA or whatever.
What are your thoughts on this?
I was just going to say, because I feel like this is like the central story, and then all the other ones are kind of playing off of this. And I think you guys, though, it was interesting, and I think you'll see, like, you guys dove into a lot of the things that the upcoming articles are about. I think a lot, like AI, burnout, like
some might call us professionals.
You know this stuff.
And to be fair, like, we didn't know anything that's coming, right? So if we did that, we had no idea what the follow-up articles are going to be.
So following up on this, going to the next articles, this one's 57% of physicians felt like this. 55% of healthcare workers intended to search for, interview, or switch jobs in 2026. So it's over half of U.S. healthcare workers plan to switch jobs by next year. 84% felt underappreciated at their current employer. And it's a survey by education services company Strategic Education, surveying 1,500 frontline healthcare employees.
So I think the corporatization, if you will, or the consolidation in the space probably means they went from an environment maybe they really enjoyed to now a really corporate metric-driven system that really puts pressure on the individual, right?
Well,
the human being.
I think at the core of it is revenue cycle management.
Okay. Expound.
Fundamentally, revenue cycle management is about making sure that cash is coming in and that systems are optimized to maximize the revenue that's being engaged. It's the same reason you had a awesome post about taking your son to the emergency room.
Oh yeah, the good bill post.
And the phase 1, 2, 3, 4, or whatever the appropriate terminology was. I mean, that fundamentally drives people away from actual care models, figuring out what people actually want, need, or desire, and moves them into a system that is rigid.
Yeah.
And it takes the relationship out of that. So that doesn't surprise me at all. It has nothing to do with what the patient relationship is or what patient need is. It's about how we maximize the core value of that instance of care.
But this has to dovetail into patient volume too, right?
Oh, yeah.
Just the number of hours worked, right? Or the stress of the job in and of itself. I mean, an interesting corollary here, we often cite a statistic from Allstate that says 78% of employees would leave their current job tomorrow if they got better benefits. I think it maybe speaks to a broader discontent organizationally with people, whether they're in healthcare or outside of healthcare, where they're not getting what they perceive the job is supposed to give them in terms of fulfillment.
Right.
And so they're willing to leave with something just gets incrementally better than what they're being offered today.
Question for you. Are RDUs still a thing in hospital systems?
RDU.
I might be butchering that acronym, but it's the payment system for providers when they refer inside their own hospital network, and they get a bonus for that or a cash payment for that. Are those illegal now?
You're asking the wrong guys.
For some reason, I feel like they got removed, and that might be part of the issue too. Is that payment has gone down as a result of that?
Yeah.
I don't know. I might have literally had a dream.
While Nathaniel's looking at that, that 84% felt underappreciated at their current employer. I mean, I feel like that's probably systemic inside and outside of healthcare as well. But if all the things that we're postulating are true, the pressure, the metrics, the patient volume, of course you're going to feel underappreciated because it's like, no, you need to do your job. And then you get leadership pushing down on you and above them are pushing down on them. And it all trickles down to the frontline worker.
Well, and it trickles down to the patient because the patient has to pay the bill. And the patient gets pissed off at the people who are executing the bill. Just like we get pissed. shortly after you made that post about the instance at the emergency room with
Yeah.
your son, I actually had to take my son to the emergency room.
Oh, really?
And just because he was running a really high fever, but he wasn't really, there weren't really a lot of symptoms of different things. And the first thing that the nurse came in and wanted to do was, I want to do these 3 tests. We want to do a COVID, a strep, and a flu. I was like, no. Bring a doctor in here and have them look at him first, and then they'll determine what test is going to happen. And she was adamant about doing it. And she was dealing with me at 3 a.m. too.
Yeah.
And so I was not the nicest person. And I said, go get the damn doctor because I don't want to do this.
Right.
Like, I have the right to determine when and where these things happen. Give me a doctor first before I determine that this is even necessary.
Yep.
And sure enough, the doctor came in, looked at him, saw the symptoms, was like, he'll be fine. Just give him Tylenol. Right. And like, but that's
And I mean,
that's
how
it.
many
And so
hundreds
how
or
frustrating
thousands
is
of dollars did you save by just saying no?
right?
in that
And how
situation,
frustrating is that for the nurse though, to have to deal with an irate patient who literally, when she doesn't have a choice but to engage in that in that pathway. I'm sure at her core, she was like, yeah, of course I don't want to do this. I'd rather you just talk to the doctor and we establish a care pathway first. So I'm sure dealing with the patient frustration is also equally
I don't doubt that.
equally
at all.
have it like
Yeah,
influential.
okay. You're about to tell us about RDUs, but I would say the overarching, I say there's some trust in kind of the medical establishment right now as well. Like after COVID, you know,
I blame
like,
that on the politicians.
Yeah,
too, for
politicians
conflating healthcare with health insurance.
So I think you already have people perhaps entering in the medical system with an element of mistrust or distrust of the providers. So anything they say to you, you're going to be skeptical of based on what they experienced over the last 5 years.
Yeah.
So there's got to be some of that as well. All right. So
hit us with
RDUs.
Is that the right acronym?
I don't. Are you talking about relative value unit? RVU?
Yes, RVUs. Thank you.
Yeah, I mean, it
knew I
seems
was
like they're
doing
not
something
illegal.
wrong there.
That's why we have them.
Seems like they're still legal. So,
Okay.
so
maybe I just dreamed that up.
I don't know.
It might be state specific. I don't know.
I'm not sure.
When it comes to like hospital specific, like things like that.
But as I understand it, it's a system where if I go see a primary care physician, they're owned by Baylor Hospital or they work for Baylor Hospital. I was a part of their compensatory contract. If they are required to refer to specialists within their own organization, and there's compensatory value tied to what they get paid by that system, by the number of referrals that they make.
Incentives. Yeah. Okay. I get it.
I mean, the one thing I'll just say about this article too, I think like the underappreciated thing is interesting because I think that's like, it's just like a negative feedback loop kind of thing of like, I think that's where in a lot of like service jobs now, you know, people complain about like, oh, the service here sucks compared to what it used to be. Like, I feel like a lot of it is, I feel like a lot of it does come down to people feeling underappreciated though.
Yeah.
You know, I think if they felt more appreciated, some of it is just people don't care, but a lot of it, I think if they felt appreciated more, they would care. So.
I mean, that's 99% of what we talk about in benefits. How do we make people feel valued at work by using benefit programs?
Hey, I don't say this enough. I appreciate you. Nathaniel.
Well, I was going to say, I do feel appreciated. So thank you.
If you find yourself in that 84%, just let me know, man. I'll make sure to tell you you're appreciated and make sure you know it. But it's funny. I don't know if this is a generational thing, but there was a study not too long ago. I don't know if it was Gen Z or millennials that even perhaps ahead of actual compensation was getting recognition or acknowledgement for doing a good job from their superiors or their leaders was like actually as important or more important than the money, which is crazy, but I kind of get it at the same time.
Well,
like we have salespeople that they get a good amount of money when they sell something, but getting recognition internally at a company meeting for doing something great,
getting like an award
that,
or something,
that actually gets some of them as excited as the check itself, which is cool.
The leader of SHRM at the HR Southwest conference said that SHRM data now shows that medical insurance is the number one thing that employees care about.
It makes sense, man.
It's crazy.
It's crazy, but
More than salary, more than appreciation, career growth, all of it.
because they just see the downstream effect of if it goes wrong or they're inadequately covered, like you and I talked about earlier today, is just the catastrophic effect that can have on your finances. So now you are concerned that as much or more so than even what you're being paid. As long as you're being paid at a level that allows you to continue to live your style at whatever life you aspire to, knowing that you're not going to go bankrupt on the other side of bad benefits is it's got to be more important.
Oh, yeah.
All right. Well, we're holding this up. So let's go. All right. Let's go next.
So this is talking, Kyle, you were talking about physician reimbursement. Physicians are working more, but reimbursement isn't keeping pace. Report finds this is by the Kaufman Research Group. So physicians are 11% more productive over the last 2 years, but compensated 2% less. And Medicare reimbursement for physician services fell 29% from 2001 to 2024.
So that's interesting to me because inflation should be pacing that up, I would think. But maybe that has to do with what we were talking about with because they're being purchased, some of these physician groups are being purchased, there's less competition of independent physicians, and they still have to compete with the hospitals who have a larger share and are competing amongst themselves. And so maybe that's how it's getting balanced out. I don't know.
Yeah, I don't know. I mean, I wonder, is that, so that I see when adjusted for inflation, I don't know if that applies above. Are they actually getting 2% less than they were 2 years ago,
it's based
or
on
adjusted
inflation.
for inflation?
Yeah,
Okay,
it's based on inflation.
But so does it sort of expound upon how they're more productive? Is more productive just mean higher patient volumes, or is there technology that's allowing them to be more productive at the same time?
Part of that's on the next slide.
Okay.
I guess we can just go into the next slide.
Yeah, sure.
So next slide. AI scribes reduce physician burnout and return focus to the patient. So it did say a lot of it was the technology, like you can use AI to, but this was actually really interesting to me going into this. Physicians now spend half their workday at their computers documenting appointments. AI may be able to help. And there's, this is an article by the Yale School of Medicine. They studied 263 physicians at 6 U.S. health systems, started using AI scribes to like record data when they're with patients instead of them having to go sit at a computer. 74% reduction in burnout.
Yeah. So, I mean, I guarantee that most of the administrative roles at doctors' offices and hospitals will be fundamentally eliminated by AI in this capacity.
Yeah.
At least the record keeping aspects. Obviously, judgment-based decisions still.
Well, I just think about, so transcription software, we use our own note-taking tools and things like that internally for our sales calls. It's pretty astounding of one is how accurate is it in capturing the transcript, but two, summarizing the discussion, picking out the key elements and action items to follow. So think about it, the use case for doctors, if they were spending half their day at the computers before, that reduction in burnout comes from the reduction of literally manual typing of notes. Like, I mean, how much more freeing to them is it to go, oh, I get to focus more time now on the actual patient care and the thing that I spent 20 years studying versus typing notes on some medical record system?
Well, and you have to wonder whether or not that's going to create another dynamic where their employers will start forcing them to see more patients to replace that time frame.
Yeah, and I think that's kind of what the previous article was getting into. Yeah, like that, where it's like they are going to have to be more productive in terms of they're seeing more patients, being more efficient with their time, which is good, but it's
not necessarily, because the entire premise behind direct primary care is fundamentally that you're going to spend more time with your doctor engaging in real healthcare interactions rather than me looking at a chart for 7 minutes because I have to then burn out to the next one.
Yeah, yeah,
that's true.
Yeah, as long as to me is there's a, it's a supply and demand effect. Like that DPC model is great in so much as that we're meeting the demand for DPC and have enough doctors. So like I would be really remiss to say it's a good thing that you now free doctors up to provide more care and then you just load them up with more patients to care for. Like, come on. Yeah. I mean, at some point, this is where
it at least strikes the balance.
The GDP overlords that are forcing people to work till they, fall over might say, you know what, we're good with a little bit of like delta here where you get a quality of life component to now having more free time and not just give you more work as a result of it. But anyways, it's interesting.
Yeah, for sure.
I've heard this, and I think this is actually one of the best applications for AI inside of it's healthcare.
It's crazy. If for 2025, you don't need to be typing out.
If all it is note taking and chart completion, I mean, the whole purpose of EMRs is to make the system universal and easy. Yeah. You could have an AI fill out the EMR and take the notes, then what's the problem?
Yeah, and one of the things I think I remember Donish talking about, since we mentioned them earlier, is their model keeps kind of a permanent record of the interactions over time and makes that accessible. So like that doctor that saw you a year ago for an ear complaint can immediately access those records and remember, oh yeah, that's what we talked about, and here's a video of the interaction and all those things.
And the power of data, especially on the data points of care in terms of successive care pathways and successive prescription and what services that individual might need for whatever condition. I mean, that's a powerful predictive tool, A, and B, it could massively improve the quality of care.
Yep.
Cool. So any more comments? Those first four are specifically focused on physician experiences. Do you guys have any closing?
No, just that.
The only thing I'd say is we don't want physicians to be burned out. I mean, let's just say that is fundamentally true.
We need more high quality doctors who see less patients and get reimbursed a reasonable amount.
Yep.
So this is our last article. It's about physicians, but it's a bit different. But I just thought this was really interesting. So according to this article, nearly 3 million people in 200 counties nationwide in the United States don't have access to high speed or reliable internet, primary care providers, and behavioral health specialists.
Interesting.
According to analysis, they generally live sicker and die earlier than the national average. So this, there's a chart on the screen here.
Yeah.
It's all the areas that are in black they just have like
Total blackout?
Yeah. No, either it's like
Yeah, you can see
they
like
don't have doctors and then they don't
Big
have
Bend over there. There's nothing out in that part of the desert.
Yeah.
Yeah. But I just thought that was interesting because it's one of those like you think of we're in 2025.
So telehealth doesn't reach because they don't have reliable internet service?
Yeah, what happened to my 5G commercials where we have the largest nationwide network?
Yeah.
Or Alaska looks like it has terrible coverage in general. I guess the purple is the second most severe kind of desert of care.
As it gets lighter, it's
Alaska only has like 5 habitable places.
Yeah, I mean, some of it is just pure isolation, right, of location, which I get that. We can't solve for that necessarily.
But all of this in the Southeast really is surprising, though.
Yeah.
In particular.
Like, I think that the article was following this one kind of town in like Alabama or something where it's like they're so far away from any doctors and they also don't have internet. And it's like this, you're just caught in the middle where you don't have...
suggest a solution for this problem? I mean,
I think there's this, it was talking about like, hopefully, I think there's like a government initiative to expand internet access. And that's kind of like just kicking in. So hopefully
this would be a really interesting application for something like, Starlink.
Yeah.
Sure.
Because I got married out in the Big Bend area where that West Texas blackout spot is. And the only internet that these people had was Starlink. There was no other option. There's no cables. There's no nothing, but it worked great. So, that might be an avenue.
Here's a question for you. Should internet be like a public good? Internet access.
I think at this point, yes.
Okay.
We're so tied into everything that we're doing with the internet. I don't see why it shouldn't
almost
be
like
treated like
water
any other,
or something.
just like any other utility.
Yeah. I think at this point, it essentially is. It's so intertwined with everything in our daily lives. Like you look at the downstream impact of the negative impact of not having access.
Statistically, it has a massive impact on education, a massive impact on survivability, economic growth, opportunity. So much of our world is so fundamentally tied to that world that I don't see why it wouldn't be at this point. Yep. And the commoditization of data also becoming what it has been. Having that be somewhat tied to a public good could also potentially be used to avoid fraudulent use thereof, I guess. I'm not sure, but I'm not familiar with the regulatory space.
Yeah, I'm not either. It was a question just kind of popped in my mind, but it's so pervasive in our daily lives, and I don't, unless an EMP comes and turns off the electricity in the entire grid.
Well, but we're screwed if that happens regardless.
That's what I'm saying. So internet is going to be a part of our lives for the foreseeable future, if not indefinitely, right? So, and everybody needs access at some point to the internet, at least if they want it, right?
Well,
should be able to access it.
Especially, you just look at this. Imagine just, this is representative of not having internet or something like that related to healthcare, right? Or specific to telemedicine. Imagine what opportunities you could bring to those areas economically or educationally from all of those perspectives to improve the lives and, like you said earlier, for the GDP overlords. That's massively like going to impact productivity in those areas as well. It would just be beneficial for everybody.
Okay, so now we're going to go into the game. I realized while I was sitting over here, I'm like, this episode will come out on Halloween. So I'm going to put some spooky music underneath it.
Yes.
What's scarier than pharmaceutical commercials?
Yeah, you want to do some low budget CGI?
Man, we should have worn our costumes.
We should have.
Next year.
So what's scarier than pharmaceutical commercials? This is going to be, I came up with this idea because I was watching actually a NASCAR race with my roommate. And all the ads, obviously, because NASCAR, primarily an older demographic who watches it, all the ads are pharmaceutical ads. Yep. Right? Most of them. And so I always think they're funny because they're just B-roll of nothing. And then you're like, what is this even for, So what I did is I took 5 commercials. Here are the 5 that you get to choose from. You got to match the drug to the commercial. Okay. I'll show you the commercial. I guess if you, the thing is, I can't really display this at the same time. Can you maybe if you want to take a picture of this or something, just so you can look at it while we're going through?
Oh yeah. So with the drugs, so we know the names.
I'll cut this part out, but just so that you guys can guess from the names.
Okay.
All right. This is the first commercial, and I'll display this on screen, and you can see us react to it. I also, so important to note, I cover up any name of the drug on screen, obviously.
Yeah.
I took the audio and I just tried to find a song that was similar to the song, because a lot of them have like licensed songs and stuff. And the audio is them talking
He's
about like,
thought of everything.
this drug does this.
Master
So,
producer.
Yeah.
I also reduced the runtime on some of these because some of them are like 90 seconds, and I just cut them down.
Yeah, that's fine. It really is absolutely just B-roll of nothing.
Yeah.
Yeah. So grandma and grandpa are watching their granddaughter at a ballet show. Are we guessing after each commercial or waiting till the end?
What do you think? I'd say let's wait till the end.
Okay.
Also, if you hear police sirens on this recording,
Based on
that's
the
not
age,
commercial.
this is definitely for arthritis.
You think so?
I think so. It's arthritis.
Got the
Or I have to-
arthritis.
And I did leave in some of the. I was like, if you guys can guess, I left in
I don't
the
know who
name
the manufacturer
of
is.
the manufacturer.
Oh, God,
God,
I've
okay,
got
that's
nothing on that.
Okay.
All right.
So we'll do. I guess you want to just we'll guess at the end.
Yeah, let's guess
so
at the
just,
end.
Do you guys remember this one? It's ballet.
So grandma and grandpa at ballet. Mostly grandma. Yeah. Okay. Got that. All right.
Let's do. This is the second one.
Hopefully the folks at home will play along as well.
This one's crazy. The production value of this.
So now we have anime.
Yep.
The lights.
French anime. No
Yeah,
less.
lights have gone out over Paris. The heroine is running from some danger.
It's made by Vanda Pharmaceutical in the bottom
Okay,
left.
what could possibly this have to do with any?
Running away from her disease.
She's got a scuff on her cheek. I don't know if that has anything to do with it.
That's probably skin condition.
Okay. I think I already know which one that one is then.
She restores power to
Oh,
the
she
city.
literally restores power to all of Paris.
Yep.
Thank goodness she was on the job. Okay. And thank goodness she had whatever drug in her system that allowed her to do that. Okay.
Yeah, that like makes that, like
Isn't the production value insane?
the production value is insane, but the story art is what's driving me nuts. Like, where's the arc here? Like, what? How does this relate to the disease that this woman has?
No.
All right, this is the third one.
Okay. All right.
You got Lady Gaga.
Lady Gaga. Ooh, so high budget, got a big budget. So it's got to be a drug that's in a lot of people's bodies. Oh, I've seen this
Taking
commercial.
photos of people.
I've definitely
Yeah.
seen. Oh, this is actually the one I was thinking previously. And it's a Pfizer.
I think I know what this one is
That
too.
was brought to us by Pfizer.
Yeah, we got two more.
When do you want us to guess?
Wait, so we got two more.
I
then
mean,
we're
if you want
gonna
to just throw out, what do you think that one is?
I
I think that's Skyrim.
think that's Skyrim. Yeah, that's Skyrim for sure.
So we'll at the end we'll just go through and guess.
So we know Lady Gaga, middle one, we believe was Skyrim. Okay.
This one, NBA season starts tonight.
There you go.
I had to choose one with these guys playing basketball.
This could also be an arthritis. So I can actually move and play ball with
Rapid
my boys.
symptom relief, steroid-free remission.
Oh yeah, that's arthritis.
That is?
100%. I mean, I think so because
Probably. So guys,
like one of the ways you
middle-aged,
treat the
right?
joint pain is steroid injections.
Okay.
No,
Yeah, I mean, yeah, you're
and
right.
he's of the right age demographic.
It's an AbbVie. Okay, AbbVie. So that's
Right.
Honestly, almost every commercial I see, I think is for arthritis
that or psoriasis, eczema.
or Crohn's disease.
Yeah, Crohn's disease, ulcerative colitis.
All right, this is the last one. Yeah.
Okay. Music teacher.
Heavy use of fingers and hands
Yeah,
and arms.
doing some-
See, also could be arthritis.
Could be arthritis. That's the trick. Is all five are
It's all arthritis.
I'm thinking she's now free from her Crohn's. Nothing is everything. Ask your doctor about. It's got to
learn
fit
how
in that
AbbVie
square.
Could help you.
It's got to fit in that square. Okay.
So I'll throw this back up the names of the drugs.
Okay. So did we get Lady Gaga Skyrizi correct? I feel like that's 100%.
Do you want me to tell you now, or do you want to guess them all?
What do you think would be more fun?
Well,
I think it's more fun if you name everything.
Okay,
You match up 5 up, and they'll tell you.
All right. So Kyle and I are in agreement. Skyrizi is
number 3.
Lady Gaga number 3. Okay. So let's go in order.
Yeah. So number 1 was the grandma at the ballet.
Do you have pictures of these things or no?
I don't. I can pull it back up real quick. Though.
Okay,
grandma at the
grandma at
ballet.
the okay. No, we
So
can just
that's
stick
Do you
there.
think that's
fine.
arthritis? Because she was sitting and watching something. She wasn't doing physical stuff.
I don't know. I'm just gonna guess based on, and this is so stupid to say, but I don't really have anything else to go off of. But I think ODT.
What does that mean?
O means old. I don't know. So we're going with that one. Nurtec.
So it could be osteoporosis, right?
There you go.
And it is Regeneron medicine. So we're maybe regenerating some bone density. All right, I'll go with you. I'll do ODT.
Okay, so you're saying first one is
Nurtec ODT.
Okay, all right.
Okay, so number 2 is the anime.
Okay, number 2 is the heroine
this
turns the
one.
lights back on in Paris.
I'm going to go Ponvory just because it sounds French.
I'm going Rinvoq.
Oh, there you go. There you go.
Rinvoq. I don't know. So Rinvoq is so you got. Can you remember this? He's going Ponvory. I'm going Rinvoq. Okay.
Yeah.
All right.
So you agree Nurtec was the first, Rinvory versus
Yeah.
Rinvoq
Was the
versus
anime
Ponvory.
was
Okay.
Yeah.
Okay.
Rinvoq or Ponvory.
And then we got Lady Gaga.
Then we got later.
So
That's
she's
Skyrizi.
We already said Skyrizi on that.
Yeah,
We
I
agree
feel
with
good about that.
And then
because that's the most household name too, and I've seen that commercial before.
Right.
So now we got the dudes playing basketball.
yes.
That's what I think would be.
So you've got Rinvoq and Ilea left. I've got Ilea and Ponvory left.
I think Ilea is the guy playing.
Okay. I'm actually going to agree with you. I think Ilea. I don't even know what the heck that is, but
Neither
I'm
do
going
I.
Ilea.
Okay.
Okay. And then
the last one
Yeah. I
is
I just know what Rinvoq treats
this
versus
music
everything
teacher.
else.
I don't even remember. So I'm going
Rinvoq here.
Yeah, and I'm going Ponvory, which is probably wrong, but I'm left with one. Okay,
right.
so what are they, Nathaniel?
Lay it all
Big
out.
So
reveal.
I think the only one that was correct was you said the anime one was Ponvory.
Oh, okay.
That's the only one
we got right.
That is the only one.
Are you serious?
So what was Lady Gaga? Was that
the hell?
Rinvoq?
I'll go through in order.
Okay.
So this is Ilea, which is an eye disease. That's why I keep showing shots of her eyes.
Oh, okay.
It treats eye diseases like age-related macular.
That he
Makes
says
sense
that.
now.
It makes so much
Dude,
more
it
sense.
does
Like, it's so on the nose.
So I put. I also wrote down the cost of each of these. So the annual cost of this one is $10,000 out of pocket.
Okay. Wait, take that out of pocket, but like 10,000 is the actual price or what the member would pay? Because
I think that's what I don't know. I tried to just look up the out-of-pocket cost.
Okay.
So,
All right.
So the second one, the anime is Ponvory, which treats multiple sclerosis.
Okay.
I don't know why that relates to her. I mean, I guess it's like she can climb and stuff and run.
That one's got probably a very large price tag.
It's $84,000 to $100,000 a year.
Yep. MS always comes up in our on stop loss conversations. Okay.
So the Lady Gaga is actually Nurtec ODT, which is
I don't even know what the heck that is.
treats and prevents migraines. Which maybe I'm like, I guess it's because there's the
Did I
bright
miss
lights and
something? Does
everything.
she get that?
I mean, she's
Doesn't-
an
Yeah,
actual
actually, that's a
patient.
good point. It does say that. I didn't see that. Yeah, I guess it's the lights.
Oh, actual patient.
Yeah, I guess it's the lights.
You're all supposed to be actual patients.
So
but-
so out of the kindness of her own heart, Lady Gaga said, "I will represent this drug because it's done so much a profound effect for me.
Yeah.
Let me be in this commercial for free. I'm assuming as well.
and so the annual cost of that
Allegedly.
one is $13,000 to $20,000.
We don't need to get sued by
13
Lady
to 20,
Gaga.
allegedly. Great singer. Okay.
Okay, so the basketball.
Yeah, what's the
This
best?
is definitely arthritis. Tell me it's
It's
arthritis.
Rinvoq. It is for Rinvoq. So the last two, I mean, obviously you know Skyrizi is the last one then.
Yeah.
This one's Rinvoq. Both of them kind of do the same thing, it seems like. So Rinvoq treats rheumatoid arthritis, Crohn's disease, and ulcerative colitis. Skyrizi basically does the same thing, but Rinvoq annual cost from what I saw was $17,000 to $30,000 a year.
Yeah. Skyrizi is going to be closer to like 240, something like that.
Jeez.
Skyrizi, I wrote down it's at least $120,000.
Yeah.
So
Well,
this
at
one's
minimum.
This one's Rinvoq, and
The
then
claim cost is the claim cost per injection is close to 21,000.
yeah.
And then
Does it
the
have a facility, like an administration cost? Like,
well, as I understand it, you get 3 infusions and then you move to an injectable.
okay.
And the injectable, each one costs anywhere from like 18 to 21,000. But then the rebate on that brings it closer to 10. So that might be why they say 120.
Okay.
So
No rebate. So Skyrizi.
Skyrizi
That's
was
also
the
why you
teacher.
should
And what does
source
it treat
things
again?
from your
Skyrizi-
instead of using your PPM.
So Skyrizi does arthritis, psoriasis, Crohn's, and ulcerative colitis. So it just added psoriasis,
It's like
but
a cure-all.
yeah, just cures all
Anything
your
you
ails.
have, you can
Yeah.
take this.
So
We'll be
yeah,
back
that was the
to
game.
Teaching music class in no time.
I thought we were going to do way better
We did
than that.
terrible. I think I was 0 for 5.
You were 0 for 5, so I win. But anyways,
won,
the-
yeah.
that's
You
not
technically
that's
did
not what's
lose.
really important.
Actually, I'll leave it. Yeah, so that's I came up with that game like months ago. So I'm like, I'm glad we finally got to do it. I came up with
Right,
that
there
like
you go.
July,
That was a
I
good
think,
game,
so,
dude.
Yeah.
That was hard, actually. All right. So what's next? Podcast reviews?
Yes.
Episode reviews? Everybody's favorite part.
Everything's all jumbled up here. Okay.
Me talking backwards about podcasts I've done.
So I'm just gonna play a clip from each episode and just talk about them. I chose 4 that I think are like the most important over the past couple months, but that's sorry to anybody who's not selected.
Going back to the car analogy, that race car you got that you studied all the components and now you're just tweaking horsepower and how much can you get out of it? And that's what it feels like. You are really optimizing the horsepower of this engine you got running for you. That is your employee benefit plan. And everybody likes it.
Classic Chevrolet. The guy's Bentley. I forgot his last name, Bentley, but he's Durant. Yeah, I was going to say Durant. Really interesting guy because he was like not the oldest son. So he didn't sort of get to inherit running the dealership. He got like, the second thing we need you to look at is benefits. And he dug into benefits and like loved it. And it's like all about self-funding. And,
that's awesome.
Yeah. And so his sort of joy talking about it is actually how he is, how he acts about it.
He definitely has the passion. That's for sure.
So real Corvette in the background or no? Did we shoot this at a dealership?
Yes. The chairs are too dealershipy.
Nope.
Damn it. It's actually this chair.
Yeah.
Oh, damn it. I should have just looked down left.
Green screen, baby.
Yeah.
Shout out to Nathaniel and Dustin.
That was a fun day shooting that one. Next is...
Oh, and shout out to Riley, too. Let's give Riley some shine as well.
They're at an all-time low.
What's that?
Said my powers of observation.
Yeah, we're tired. We've been talking for a long time. Ooh, this one's a good one, Nomi.
The business side of healthcare is horribly broken. So it really came down to building a business in healthcare that could solve for the business problems of healthcare, which is it's really hard for providers to get paid. And as a result of that hardness to get paid, the buyers of that care, which would be employers and employees, the cost of that care continues to rise because providers are trying to solve for the problem that they can't get paid, and they have to make up for people who are paying.
So shout out to Nomi.
Episode.
Did you pick Nomi because they're a sponsor of the show? I feel obligated to do that.
I was like, we got to shout him out. Yeah.
Oh, the stat I've cited here recently came from this episode, which he was talking about how roughly like 25% of costs in a hospital system where he was up in the Minneapolis area was administration. Mm-hmm. It's like literally like 2,500 people were there solely as administrators to go collect reimbursements. And it just kind of speaks to the scale of the problem of that bloat.
That just hollers back at the AI conversation.
Yeah.
I mean, you solve so much of that cost that way.
Yeah. Get rid of some jobs.
So I just want to clip that.
Get
rid of some jobs.
That's what I know.
Get rid of some jobs.
Kyle says, "Get rid of jobs."
Yeah.
All right.
Yeah, all right. No, yeah. Don't you put that evil on me. All right.
What I perceive this conversation is really going to be about is perhaps the future of the way that we source food, prepare food, the quality of the meat, obviously, Chef, that you're going to talk about. I think there's a bigger picture conversation here that isn't just about the world of healthcare and benefits that I operate in. We're talking about human beings, the optimization of food infrastructure in the United States, as lofty as that sounds.
Yeah, and that was one of my favorite episodes of the year because it had nothing really to do with benefits. I mean, we tied it in slightly. But so Chef Austin Simmons was the chef. Have you heard of this guy? Mm-hmm. Yeah, he's amazing. Best steak I've ever had. Brought some home to my daughter who's 8. Yeah. She even goes, "This is the best steak in the world, Daddy." But we actually talked about how he crossbreeds cattle and like raises them properly. And it was everything into like food infrastructure to logistics. And it was really, really cool. But it's like, how do we overhaul our actual whole food system to make people healthier?
Right.
Like that was one of my favorite conversations of the year.
And I want to say I was in Denver last week and me and my dad went to a steakhouse and they had prime beef on the menu. And I was like, well, prime beef's like so inconsistent and stuff just from this episode.
Yeah.
So I knew
So you only order from Chef Austin Simmons now, right?
Yeah. Yeah. I order it to the restaurant. And then
to the restaurant.
Yeah.
Hey, cook this for me.
Yeah.
Your meat sucks.
Yeah.
BY owned steak.
Oh, Jay Ritchie.
I absolutely think we're in that tightening, hardening market. I think the days of the employers who are, let's call them average risk, seeing single digit rate increases, that's gone.
Yeah.
It's going to be a double digit rate increase market going forward.
So as a consultant, react to that. So that's the CEO of Tokyo Marine HCC.
Right.
Yeah.
Well, I also think that I fully agree with what he's saying, but simultaneously, this emphasizes the need for claims management solutions. Mm-hmm. And the focus on the business and the consultant to stop just waiting for the network to solve your problems or the TPA to take action and to take a little bit yourself. The easiest way that people start doing that is sourcing programs on RX. Stop waiting for rebates because that Skyreezy conversation, $18,000 to $21,000 per claim. You may get a $8,000 to $10,000 rebate, and that's all well and good, but that's still a stop loss claim.
Yeah. Oh yeah.
If I can take the rebate out of the equation, get $6,000 per fill instead of the 21, then I've lowered the actual claim threshold, because people forget, and I teach this in the class too, that people forget that rebates are good for you. They're not good for the stop loss carrier.
Yeah.
So if you get to lowest net cost, that benefits them and gives them more reason to
So
stop
whenever we have
jacking
to
your rates
apply a
up.
laser, I don't get excited, but whenever it's a prescription drug, I go, oh, we can actually solve for that one. For
Right.
the most part, there's a few that
Right.
really, they're orphan drugs with no alternative.
Right.
But I'm like, I can solve for that if it's a RX related claim, especially if it's something like Skyrizi.
100%. So
And I
you
think
have to
people-
have those.
People will kind of demonize the carriers. And I don't remember the context if Jay was solely talking about stop loss or if he was talking about the insurance market at large in healthcare. I can't remember. But think about where a stop loss company fits on the chain. They're after the claim has been processed and adjudicated, is now being submitted for reimbursement to pay back.
Right.
They have really very little ability to actually effectuate the cost of that claim.
Absolutely.
So they're just reacting to 18 to 24 months from now what we think things are going to cost, and we have to price our insurance as a result of that. So claims management, like you said,
Well, people like you said,
is
they
the
love
root of
to beat up on the carrier, and there's probably a few reasons here and there that they should and will. But by that same token, I tell one of my clients, even employees during education meetings, this is all a very simple math equation. It's premiums versus claims. You put more money in than you're taking out, you're going to be good. You've taken more out than you put in, you're going to have problems. So what are you doing to control that equation?
Yep.
What are you doing to handle that? Because if all you're doing is hope is not a strategy.
well, let's use an example. Like we have our 30% rate cap. We have people with 300 or 400% loss ratios. Sometimes it happens, right? In the world of stop loss, they'll still come to us and be like, well, they want to negotiate. It's like, no, you paid 3 times less than you received in reimbursement for claims. You're going to get a rate cap. Like that's the reason that thing exists. So rather than beat up the insurance carrier that's actually constrained at raising your prices to where it needs to be, they've been constrained, go solve the problem that undergirded your loss ratio so that you don't get a rate cap again the following year. But I mean, you still buy insurance for the purpose of protecting you in unforeseen losses, right?
100%.
So, all right, so we got to move on to this. I know we got a time constraint here, so
Yeah, this is just
do we
the
have
last
a
part
call
of the show.
or
I
anything?
have a text
Okay.
somebody sent in. So
Is it
this-
coherent? Because not all of them are coherent.
It's well, I will say the guy did put in like kind of an ad for his company. I took that out. This is anonymous, but this is for Ask Spencer Anything. You know, call or text 469-213-6381. Leave us a voicemail or text, and Spencer will answer it.
Okay.
The question this time is a general question for your podcasts and self-funded insurance. What will it take to get drugs like ketamine, pain management, ketamine-assisted therapy, and psychedelics like psilocybin, MDMA, and ibogaine approved for full reimbursement? Thank you for bringing this very important topic to the public.
The easy short answer is time. I think it just takes time.
I agree.
General level of awareness, longitudinal enough testing to prove that they're safe or safer than the alternatives. And I think what you see is when something like ketamine, we covered ketamine assisted therapy here before, psilocybin kind of fits in that category for PTSD and things like that. You have to eventually get enough groundswell of demand where people are saying, I need access to this. It works. It's been proven to work thousands and thousands of times. So therefore you should now cover it as offer as a benefit.
Right.
So that will then push politicians perhaps to change laws. You know, I think, who was it on Rogan recently? Was it Romney? No, it wasn't Romney. Oh, shoot.
I'm not sure.
Rick. Oh, he was on talking about ibogaine on Rogan a couple months ago, where in Texas, I think they have now allowed for ibogaine the treatment of, I think, PTSD. And it was like there was enough groundswell of demand, and finally they got a politician to pay attention, which then turned into changing of legislation.
Right.
So time for me.
You also have I think with a lot of the things on there, you have the issue of commercial use of controlled substance that are scheduled on the DEA no-go list.
Yeah.
And then in addition, you know, the FDA process and how do you source that? Do you turn the federal government or let loose a manufacturer to commercially manufacture, I mean, what is also used as a recreational substance?
Yeah.
So I think you have to have more testing. You have to have more case studies. There has to be, again, public demand before you're going to see anything like that. But in the meantime, that also doesn't mean that you can't make use cases on a case-by-case basis, right? If you have a patient that qualifies for these treatments legally, and then you can then make an argument and show a financial rationale to a reinsurance carrier, most of them are going to be on board with that. But you have to be able to validate financially to that insurance company that This is going to save you money. You are not going to have to pay a claim, or you will pay less claims as a result of allowing these two patients to pursue that or have that covered under that metric. And here's the financial resources to back that
Well,
up.
and two things. So Rick Perry, couldn't remember Rick Perry. It was Rick Perry. Two, there's a reason why it's called
Former governor.
Yeah, I couldn't remember Rick Perry. Ketamine assisted therapy. So what does that imply? Somebody's overseeing the administration
100%, yeah.
and therapy in of itself, not giving you ketamine and saying, good luck, okay, go smoke it at your house or whatever, right? So that's a completely different thing, but people associate the recreational use of the drug and perhaps the abuse or overuse with very carefully controlled administration and oversight of the use of the drug. Those are two wildly different
Yeah,
things.
absolutely.
My suggestion is like, in Mad Men, they're always like, if you have a bad market recognition, just change the name. They just need to change the name. Don't call it ketamine assisted therapy. Call it something else, Like
Call it cat.
Call it cat, sure.
Yeah.
But like,
Right.
I would say just don't say the word ketamine with it. Just be like, it's whatever.
Well, yeah.
Assisted therapy somehow.
And that's a really good point, is that the assisted aspect, like the medically oriented nature of the therapy versus
Yeah.
here's a bunch of ketamine, go home and take it in these doses.
Well, so think about let's use a probably kind of a corollary. So testosterone. People take testosterone, HRT, TRT. That's like commonly done in middle-aged men these days. It's overseen by a doctor. You get blood work, and they give you steroids. That's far different than a bodybuilder buying it from a buddy in the gym and abusing the dosage of said steroids and stacking them on top of each other.
Yeah.
Two different things. One is accepted very widely. Another one is looked down upon.
Right.
All that changes is the oversight and the clinical part of it.
Like you can't get morphine from a pharmacy over the counter.
Yeah.
Like it has to be administered by an anesthesiologist. Like it's
There you go.
different.
So my hope is that over time that actually changes.
Yeah. It's
a great question.
I do too, because fundamentally, I mean, from everything I've seen, at least study wise, that the results seem to be very favorable and positive comparative to the use of antidepressants and other things, particularly in PTSD cases.
cool. Well, thank you, Kyle, for joining us.
Yeah,
on this episode of
absolutely.
Last Month in Healthcare. Thank you, Spencer.
Best one yet because you were here.
Well, I'm a heavy hitter.
You are. Awesome. Well, thanks guys for listening. Nathaniel, obviously these are fun. Sorry about the delay. We had a long couple months, got into busy season, things came up. So we hope to keep doing these every single month to do the Last Month in Healthcare special episodes. So look forward to doing one 30 days from now.